Hi, this is Brian Kim. I'm going to share with you this first Hydrus case experience. This is my first patient who underwent the Hydrus Microstent. Again, shout out to my rep, Nisha, who is really nice and very helpful, and she came and helped me with this very first case. And so I'm just going to share with you my first experience using this on my patient and just the technique involved and what I learned and how this case went. So I'm using a cotton tip to steady the eye and use a corneal marker to help me center and size the rhexis. And then I'm making my corneal marks first on the right side and then the left side, making sure the incision is parallel to the iris plane, which creates a nice corneal shelf, which allows me to achieve a self-sealing incision. This is intracameral lidocaine, and then some intracameral epinephrine, and then some dispersive viscoelastic to fill the anterior chamber and to coat the corneal endothelium. This is my triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I get a nice shelf, I turn and then enter. And push some more viscoelastic in. And these are the Hawley-Perkar rhexis forceps. I'm trying to gently puncture the center. And then grabbing the right side of the tear, I start to create the flap. You can still see the corneal mark I made, which will help guide the size and centration of the rhexis. Again, very controlled, very smooth, minimal viscoelastic egress. The rhexis doesn't tend to radialize with these forceps. It's made my life a lot easier. Burp some viscoelastic out, and this is the capsular fornix hydrodissection technique. I place a cannula under the rhexis edge, contra-incisionally, point the tip down, get a nice wave, turn the tip back up, decompress, and then I'm going on the right side, hooking the peripheral lens, trying to turn it. Doesn't seem to want to turn here, so I'm freeing up the anterior capsule on the left side, and then now it's starting to spin. So part of it is that you want to free up the anterior capsule if the lens doesn't want to spin. Don't just aggressively turn the lens. You're just going to stress the zonules more. So I lift the incision with the chopper. I go in with irrigation off, removing the surface epinuclear material, placing the chopper around the lens, turning the phaco tip vertically, subincisionally, crushing and bisecting the lens in half. That's double chop. Placing the chopper around the right heminucleus, pulling it centrally towards the phaco tip, crushing the lens between the instruments. That's cross chop. Using some vacuum and then hooking the peripheral lens, crushing and dividing that first quadrant, and then using some vacuum as well as some ultrasonic energy, pulsing it and removing the lens pieces. So again, it's a combination of crushing forces to crush the lens into smaller pieces, using the high vacuum to remove the pieces, and then if there's some pieces that get stuck in the phaco tip, then you pulse it with the ultrasonic energy. Crushing the right heminucleus, doing the same thing with that piece, using some vacuum to hold the pieces, and then crushing them into smaller pieces, and then emulsifying the lens pieces. Hooking that last piece of the second quadrant up, using some vacuum to grab it, crushing them into smaller pieces. Go ahead and spin that second heminucleus in front of me, just gently turning it. I don't want to use too much stress. Placing the chopper under the rhexis edge, pulling it centrally toward the phaco tip, dividing that lens, placing the chopper around the third quadrant, pulling it towards the phaco tip, crushing the lens between the instruments, using some vacuum to grab the piece, crushing them into smaller and smaller pieces, and then ultimately emulsifying the lens piece with some high vacuum and pulses of ultrasonic energy. Again, this is a very controlled, systematic way, very easy, very confident when I'm doing it this way. I'm not worried about any significant complications. I know that I'm using minimal ultrasonic energy, which will be great for the cornea. And because I'm crushing the lens pieces into smaller pieces, I never encounter the post-occlusion surge problem by doing it this way. And of course, because you have a nice bed of epinuclears protecting you in these routine cases, it's extremely, extremely safe. The only time you ever worry about the posterior capsule is when you don't have good epinucleus. And of course, that's usually in the context of dense lenses, Morgagnian cataracts, stuff like that, when you don't have good epinuclear protection. So again, you can see I'm divided that last quadrant, crushing them into smaller pieces, and then emulsifying the lens pieces. This is the last piece of that fourth quadrant. I always like to hook the lens with the chopper, bring it up, and then crush it. So I try not to go after pieces with the phaco tip. That's the other time when you can run into trouble. If you go after it with the phaco tip, you might accidentally grab the posterior capsule. This way, I just hook it with the chopper, bring it up, and then crush the pieces. Once you mobilize the lens, it comes out pretty easily. So you're crushing the lens into smaller pieces, and that's all the endonucleus. Going after the epinucleus, grabbing the anterior edge. By grabbing the anterior edge, most of the time the epinucleus starts to prolapse out. And I'm keeping the chopper deep to protect the posterior capsule. Again, I'm very ginger about the vacuum here. So I take the chopper out, push BSS in, take the phaco tip out. I'm going to go in with the INE handpiece. I start sub-incisionally, grabbing the anterior-most part of the cortex, peeling it from front to back. And again, because there's such good fluid control and high vacuum with this instrument, you can modulate the amount of vacuum with your foot pedal. Always try to grab the anterior-most portion, otherwise you might have more tendency to have leftover cortical remnants. You saw right there, I accidentally grabbed the posterior, so I refluxed, and then I went back and removed it. So fairly clean bag. Switch to polish mode, polishing under the rexus edge to remove any lens epithelial cells. I always polish the posterior capsule in the subincisional area. Invariably, you may see some very fine cortical material there, even though cortical removal seems a little bit tedious. I think this step is, if you don't do it right, that's when you can end up with this huge Sommerings rings in patients when you see them way after surgery. You can see I pulsed with the BSS, and there is indeed some lens material in the subincisional space I was able to grab and remove. Push some viscoelastic to fill the capsular bag, and then this is a sweeper. I'm going to polish under the rexus edge. So as I was saying, I think, cortical removal and IA is very important. It's a little bit tedious. Some people are a little bit quick with that. I think it's important to remove all that lens material because, as I do a lot of lens exchanges, I can see these dislocated lenses with these huge Sommerings rings. And I'm sure the surgeons, when they did the surgery, thinking, oh, I did a good job cleaning it up. And then you see these big rings. And so I think that, again, maybe it's not completely avoidable, but at least by cleaning it meticulously, you reduce the risk for something like that, or at least make it less severe. So I'm placing the single piece acrylic lens into the capsular bag. As it unfolds, I go ahead and go in with the INA with irrigation off, activate irrigation, making sure both haptics are disengaged off the optic. Get underneath the lens, tilting and rotating at 90 degrees clockwise, removing the viscoelastic from within the bag, putting the lens back into the bag. This is when I'm reminded, you have to do the Hydrus. So I fill the anterior chamber with viscoelastic and coat the cornea. Here I'm talking with Nisha, trying to figure out how to make my incision for the Hydrus. So remember, you're trying to get to that angle right there. And you want to start on the right side because the Hydrus is going to be coming out towards the left. So you want to create as much real estate as possible for yourself. So I made that incision. You can see it wasn't directly radial, it was tangential towards where I want the Hydrus Microstent to go. So now I'm turning the head, angling the head away from me. And of course, those of you who do MIGS, this is a fairly standard and routine part, but it's so important to get a good angle of approach. So that's the device, and you want to use a roller to expose a little bit of the stent, about taking up about a third of the window there. Want to get it in focus. Sometimes, like right here, what I'm doing is I think I'm not quite centered and focused, and so I'm having to make an adjustment here. And so that's the other thing, is make sure that you're well centered so that you can actually get good focus. You don't want to be at the end of your focus and you're in a critical step and you can't see. So you're going to angle up, literally going to angle up towards the cornea here just a little bit, about 10 to 15 degrees or something like that. You want to stab into the TM, and you want to be into anterior TM, because if you go to posterior TM, it tends to dive down and it'll come out. So again, anterior TM, stabbing, and then I'm advancing the device. It seems like it's going forward. Once you feel confident it's going in correctly, you want to level out. And so Nisha is going to tell me to level out here, which means don't put that upward tension. You want to make sure that the direction of the device is going to be facing where you're trying to place it through Schlemm's canal there. So as it comes out completely, you can see the distal most part of the injector pops up. Once you get to that point, you're all the way at the end. Then you have to back up away from the stent, and you want to pull the injector all the way towards the right. So you're backing out like you're backing out of a parking space. You want to be completely disengaged, and then you want to turn the roller back so that distal part of the injector that's sticking out goes back in. And then you can take the two edges. There's a groove at the end of the stent, and then there's a kind of a flat part on the distal most part of the injector. Those two edges can come together. You push down on the groove, push down on the stent against the scleral wall, and then you can advance it even further. So I'm just pushing some more viscoelastic in. You can see there's a well-placed stent. You can see the distal most part is not sticking out too much. And I'm looking around at the stent, making sure Nisha is approving that the stent looks like it's in great position. And she approves, and trying to see the rest of the stent here. You can see all the windows. And so she's happy. We reposition the patient's eye, and we're moving all the viscoelastic. We go underneath the lens, making sure all the viscoelastic is definitely out from the bag. So that's the end of the case. So you can see that placing that stent, there's a little bit of a sharp tip. It's like almost like a tip of the shovel. You want to stab into the TM, again, anterior TM, angling towards the cornea about 15 degrees or so. Start to advance the wheel. You can see the device start going into trabecular meshwork and then Schlemm's canal. Once you see that it's got a significant part in and it's going in the right direction, you want to flatten out, making sure the trajectory of the stent is going along the trajectory of Schlemm's canal. And then as you push, again, the tip of the injector pops up. You know that you're at the end. You want to back out away from the stent like you're backing out of a parking spot, making sure you're not hitting anything as you come out, and then pull it away from the stent, pull back on the roller so that distal part that's sticking up is withdrawn into the device, and then you can just push on the groove on the distal end of the stent, the groove with the injector tip, pushing it down against the scleral wall, and then advance it further. At the end of these mixed cases, I always like to see if there's any blanching. And so I do think there's some blanching in this area where the stent is, and it's about 120 degrees of blanching. And so I feel pretty good that we're getting some good flow through the Hydrus Microstent. And so I'm hydroing my incision at the end of the case. So, Nisha felt good about this. I felt really good about it. It felt like a very, very easy first case. I'm very grateful and fortunate that this first case went so smoothly. Of course, not every case is going to go this smoothly, as you have different eyes, different anatomy. Things are going to be different. And so it's going to be a challenge, of course, as I gain more experience handling these situations, and I'll share those cases with you here. So I hope this was helpful to you, and I thank you for your attention.